from the National Health Insurance Authority. We've got the Chief Executive Officer, Dr. Dacosta Aboagye, joining us with some solutions, hopefully. Good morning to you, Dr. Dacosta Aboagye. Thank you so much for joining us here on the Super Morning Show.
Good morning, Amazi. How are you?
I am doing very well. It's just the news of the dialysis treatment, and we've heard voices of patients who couldn't even afford to raise the 380 something, and now they have to cough up the 490 something, and that is what is beginning to weigh me down. But you have a solution. Hopefully it comes in sooner, so please tell us about it.
Okay, thank you so much, Mamabi. I think let me extend greetings to all Ghanaians. Somewhere I think last 2 months or so, dialysis became very topical in the country. So at the time, the National Health Insurance Authority was going to Parliament to obviously defend its budgets. And at the time, it was not part of that was when the president had appointed me. It was not part of the formula or the budget. So because of how topical it became, we discussed with the health committee that I think if there is something that we could do to support the dialysis patients in terms of whether it will come from our corporate social responsibility or wherever it will come from, they should give us some money in such a way that we'll be able to support. But the argument was, okay, on what basis are you going to obviously use this money? Because for our formula, for you to admit something on the formula, you have to do what we call actuarials to look at its sustainability. But luckily, there was a committee that was working on these actuarials. But again, that work is comprehensive, so it will take some time. So we just said that I think if they could support us with some amount, then we look at the modalities of disbursement. So all the health committee members were of the view that it is important we introduce a little bit of subsidy, that is a little bit of support on our formula to support the needy, whilst we await for the entire report, considering the sustainability of the scheme when it's introduced and all the other factors. So 2 million cedis was given by Parliament for us to use in support to support the needy. But when we came, when it was approved, what we did was we set up a committee, including the CEO of Kolebu, the CEO of Komfanoche, the CEO of Cape Teaching Hospital, with their medical director, chaired by Dr. Nkiasare, and I was a member of the committee. And also, we did not exclude the patients themselves. So the spokesperson for the dialysis patients was also on the committee. Now, it was in that committee that it was revealed that Parliament has approved some fees and charges, the new fees and charges, which was 491. So we decided that, okay, if it's 491, if we are working with a 491 figure, what do we do? We noted that about 80% of the patients on dialysis come from Kolebu. Now, there is a philanthropist that supports them with about 380. So if you subtract the 491 from the 380, you get 111. So we said that, okay, for the 111, looking at the fact that majority of the patients are coming from Kolebu, let's see how many sections we can cover. When we worked it out, based on the money we had, we knew that we could support only 2 sections, which comes to 222 because of the numbers. They are over 400. So for Kolebu, we had that special package for them covering 2 sections. So it means that for the 491, if you combine the philanthropic help and the NHIA help, for 2 sections, they don't have to pay for anything. Now, you come to Komfanoche, Cape Coast Teaching Hospital. For them, they have no support. So we decided that we will support 2 sessions at full cost, which is 491. And I think it is only fair that the patients from the other places also get the 2 sessions at 491. So I think it was agreed, and the committee has just presented their report. And all I need now is just to develop what we call the DRG code, so that when the patients go to the hospital or the facilities, they can access it. But I think there will be a board meeting coming up. I'll give the report to the board. Then we just start the implementation. So this is what we can do, and we are doing this because we believe that obviously we need to support. We need to, as part of our corporate social responsibility, or on a compassionate grounds, we need to do something. Again, this also has coincided with our 20th anniversary, so it is also good to give something out. So whilst we wait for the bigger report that will capture the full cost, project it over years, and for us to know the sustainability for the next 6 months, this is what we can support the patients suffering from this kidney disease. Mm-hmm.
Yeah, Doc, how soon will these this support become available to those who need it?
In fact, the money is available. It's just the mechanism. So, like I said, we're looking at 1st June.
Okay, so next month, beginning of next month.
Next month.
Now there have been some concerns, Doc, around the ability of the NHIS to actually sustain this support. You're saying that about 2 million is what you're initially looking at, while you work out the actual actuarials and so forth. But the NHIA has its own problems. We know that historically you've been struggling to keep up with payments. What will this extra 2 million do to your ability to operate?
To me, the 2 million is insignificant on our budget, so I think it's okay. And it has been approved by Parliament anyway, so the money is there for us to use. But I think over the years, I must say that, if you look at the trajectory, the insurance scheme has actually improved in terms of claims payments. So an average, we pay an average of between 180 and 250 million every month to facilities. So it is really obviously significant in terms of how much money we pay. And at the moment, we are within for lower tiers in terms of we are on track in terms of our payments. Because if you look at, we have a contract with them. The contract actually says that we should, obviously, within 3 months, we have to pay. Even though I know the Article 852 obviously removes that kind of months within. But we are on course. We are working seriously with the finance ministry to give us our releases. So for me, I think the insurance scheme is on a good footing and is doing well recently, and we must keep up to the pace. This wouldn't say, obviously challenges in organizations, we do have challenges, but we'll continue to address them as and when we go along.
So, Dr. Aboagye, do you have the 2 million, or is it just a budget? Has it been released? Is it in your accounts?
It's there, yes, it's there. If once it's there, it's not a problem.
Okay, so we're not just, because you mentioned that Korle Bu will be zero. It means that patients who go there, which is about the 80% of patients who go there, will basically pay nothing. But then you will absorb the
No, for the 2 sections.
For the 2 a week.
Okay, so my understanding is that they need 6 to 8 sections. We can cover only 2 of the sections.
Yes. So out of the about 8 a month, you are ready to cover 2 sessions.
Yeah, with the support of the philanthropists.
Right. It means that they still will have to cough up for the rest of the period for the six other sessions that they will have. They will still have to come up with the 491.
The difference, you see, what you have to know is that a philanthropist is paying 380 for them for, it's not only that, I mean, they pay for all the sessions, the 380. So we are just coming in just to support them. And like I said, what is on our budget is for the needy. You see, so we're just trying to come in with an intervention that will obviously, as we say, half a loaf is better than none. And that's what we can afford for now.
Right.
Then we look at the bigger picture.
Except that this, as you've projected, will be for about 6 months. So I'm wondering, after the 6 months, what happens?
Who knows? By that time, the report would have been ready. And it will not be the first time we go to Parliament to seek approval on our budget. But again, we don't just take decisions. We take decisions based on materials. So unless they finish the work, which is very comprehensive, I will not be able to commit to future plans. But I will be able to commit to what has been approved to me by Parliament.
Let's face it, Dr. Dacosta, Raymond here.
Raymond, yeah.
You basically provide primary health care.
Yeah.
This is not primary health care, yet you are taking on board. There's no guarantee you can give the people of this country that you will do this sustainably.
And there is no guarantee also that we will not be able to do it, because we do not have the actuarial figures to prove that. So this is why I'm saying that I think that I believe that it's a step in the right direction, because at the end of the day, we do have corporate social responsibility budget. So if we are taking 2 million from our corporate social responsibility budget to support dialysis patients, I think it's in order.
Your budget, like the budget and its what they call it, appropriations. Appropriations were passed end of last year. Why are we still having, after or almost going into the ending the second quarter, a conversation about this release of 2 million to people who are supposed to be benefiting from it today? Why is it taking more than 2 quarters for us to discuss moving into the next month?
Raymond, I have my appointment in February ending. Okay, March is when I started. When I went to Parliament, because even appropriation was done, I mean, that was in December or so. But you still need to go to the Parliament as a whole or something to defend it. So, and at the time, my predecessor had been moved to the ministry. So it has gone through a series of processes. So I think that within the time that I came to now, I think we are on course. And we've worked so hard. The committee works almost every time to make sure that this has been done. So for me, I think it's really positive. Looking at the time I came in, and I think it's a very good intervention at the right time to support these patients.
Yeah, that some would agree that is an intervention that's in the right direction. The concern here is whether or not, first, the release we are talking about would really start in the first week of June, and 2, when I walk in or any of the patients walk in the first week of June, there won't be a new excuse for them not to have that kind of support. That's the main issue with many people. Let's not forget, when some amount of money, and that's from the ministry, was supposed to have been released to Kolebu, they later on said the same renal unit had payment difficulties and that they were reviewing a certain contract before they make the payments. I'm talking about the bottlenecks that may make it difficult for this to be rolled out, which is already 2 quarters late.
Raymond, already we do pay Kolebu for our claim. We do pay the teaching hospital. So for me, I think it's not a problem. The difficult work has actually been done. And we are just 2 weeks from the implementation date. So I think we shouldn't worry too much. For me, it's just a matter of just... And the good news is the CEOs of the various teaching hospitals were part of this decision that we have taken. Their medical directors were part of these decisions we've taken. So, I mean, it will not be right for them not to implement it when we have given them the go-ahead to do it from 1st of June. If we do so. So I think for now, I think we should hit it slowly, but we'll get there finally. I'm sure that we can start on the 1st of June.
All right. So from the 1st of June, we should expect that this intervention will kick in. But
Yes.
kindly confirm again, this is not restricted to Korle Bu and Komfo Anokye alone, is it?
Oh, no. So I've said that it is for, just that they have different packages. So Korle Bu do have their package. Of Anokye and Central Region, they do have their package.
Okay. Well, I guess we will leave it here and just do the necessary follow-ups when it takes effect in June. But we thank you so much for your time this morning, Dr. Dacosta Aboagye. All right. That's the Chief Executive Officer of the National Health Insurance Authority, Dr. Dacosta Aboagye. This is some sort of intervention. It doesn't solve the entire problem, guys, but it's some sort of solution, if you like.
No, I believe that, yes, it's a step in the right direction. At least it's some relief to the people already suffering this. Marvin, the issue is bigger than this kind of relief that we are actually providing. When in 2013, Elliot Tanner Cranton, doctor, authored the 50 years of hemodialysis in Ghana, current status, utilization, and cost of dialysis. He revealed that the number of dialysis centers, there are 51 dialysis centers in Ghana, with 40 currently functioning. Most, that's 65%, are located in Greater Accra region. So, do you get the point? Most of the dialysis centers are located in the Greater Accra region.
This was authored when?
This is in 2013. Now, if you move it along, you also will get to know that 17.5% of the dialysis centers are in the Ashanti regions. 7 other regions have only one center each. So imagine having to live in a region where you have to travel not only to the regional capital to go and get a dialysis machine and its access and all of that. The patient to machine ratio, there are 1,195 patients at the time receiving dialysis, yielding a ratio of 4 patients per machine, which is supposed to be the case. But the reality is very different. The dialysis prevalence is 38.8% of patients per million population. Centers have a median of 20 patients with a higher number in public versus private sectors. And the quality of care, 57.5% of the centers lack a resident nephrologist. Ghana has a 0.44 nephrologist per million population. 0.44, yes. 7 regions covering 18.5% of the population lack any dialysis centers. 92% of estimated kidney failure patients have no access to dialysis at all. These are still very serious issues that require a broader intervention than just what is being done. Even though I applaud this one, and I hope that it was deployed yesterday, but there's still a bigger problem with renal healthcare that we should be able to get around with.
Yeah.
What we do in this country, like we did with the National Youth Employment Program, which became a permanent solution, was that we roll out small interventions to bigger problems with the hope that we will do bigger intervention in the future. It never comes. And I'm expecting that we will not sleep on this one. We will get into the bigger conversation whilst applauding the NHIA for the impact.
You see, this is what I was talking about earlier, that sometimes the solutions that are deployed are not solutions to the problem. They are just to shut us up. I mean, I'm not saying that what the NHIA is doing is to be rubbished. No. Hopefully that will even save lives. And for that alone, it's a good thing. But it's not the solution to the problem. What is the problem? The problem is that people with kidney disease in this country cannot get adequate care. And those who cannot afford it. That is the problem. Okay, so Raymond has given you the statistics. Even if the NHIA were to say that we are going to fully fund everybody's dialysis treatment, you will still have people in the central region queuing up the whole day just to get access to a dialysis machine. Many of them returning home because they couldn't. And then in a month or two, dying just because there aren't enough machines. So the problem is huge. And you see, this is dialysis, this is kidney. Look, I keep saying this, in other parts of the world, in 1990 something, somebody ran a marathon in the UK, and the person had been living without kidneys for 3 years. Onye kidney kurumpo, they've both been removed from his body. But every other day, he goes to hospital and spends a couple of hours on a machine that does the job of his kidneys for him. Now, look, your kidneys are important. Without your kidneys, everything you eat is potentially poison. Everything you eat and drink is potentially poison to your body if you don't have kidneys. So the dialysis machine just filters your blood so that you are not poisoning yourself with the things you eat and drink. It is a very simple solution that has been devised decades ago, and in other parts of the world costs absolutely nothing to deploy. But here in Ghana, even the machine to do it, we don't have. Before you come and talk about the cost of the consumables. So look, what the NHIA is seeking to do is, it's not a bad thing. It's a positive, it's a step in the right direction, but it is still plaster on cancer.
Well, we know the NHIA is only an agency, right? There's a mother ministry, the Ministry of Health. There's even the health service as well.
Ghana Health Service.
Ghana Health Service, which also is an agency, but way bigger than the National Health Authority, National Health Insurance Authority. So there are a lot of places that we can go also for solutions. We will definitely trust us to be pushing these angles on this.